Good afternoon, everybody. For those of you who don't know me, I'm Chris Paxson. I'm president of Brown University, and it is my great pleasure to welcome all of you to the State of the School of Public Health. This is an annual tradition. How many years have we been doing this? 4? Okay, that really is annual. And it began under Dean Ashish Jha's leadership. And it's just a wonderful opportunity to kick off the academic year and take stock of the school's amazing progress, remind everybody what a great job you all are doing, and to learn about the strategic vision and the goals for the future of the school. Now, last year I was here with you celebrating the school's 10th anniversary. So we're heading into decade number 2, which is exciting. The school is certainly no longer a startup, but it's a major force that's driving public health locally, nationally, and globally. And I look forward to seeing the school continue to do exceptional, high-impact science that can be translated into the lives of people in this city, in the state, nationally, globally. And that's, I think, everything that you are committed to doing, too. So my primary role today is to introduce Dean Jha. Maybe in this audience he needs no introduction, but I'm going to do it anyway. As you know, he's a globally renowned public health expert. He's been an exceptional leader for Brown. He somehow still finds time to see patients in everything he does. And this is the second time in the past few weeks that I've had the pleasure of and privilege of introducing him. He was the keynote speaker at Brown's convocation this year, so welcoming all the new incoming students, which was really a lot of fun. Now, for those of you who weren't there, in my introduction, I noted how during the pandemic, he became the trusted voice on how people should protect themselves, protect their families, learn what they needed to learn to get through a very scary and anxious time. And in my introduction, I noted 2 reasons why I thought he was especially effective at doing this. And they're important for public health more broadly, so I want to highlight them here. One is that he offered incredibly clear, jargon-free, accurate explorations of the evolving science of the COVID-19 pandemic. We learned that we didn't all have to have MDs or PhDs to understand what was happening. Clearly, MDs and PhDs are good if you want to get really into the details. But people could understand what was happening in a really clear way. And I think that's an important lesson for everybody who works in public health. All of you are scholars and students, and you are or will be in positions where you have to communicate knowledge about public health, not only about the pandemic, but all kinds of things, to broad, diverse audiences if you're going to influence public health and health policy. So, thinking about how to do good communications around research, vitally important to what you do. The other thing I emphasized in my introduction is that he always told the truth. And the truth was always grounded in science. And so if the science supported something, like wearing masks, he would say so. He would tell you why. If the science was still unclear, so the answer really was, we don't really know, he wasn't afraid to say that too. So, the questions that I remember you taking were things like, how long will the vaccine protect me? We don't really know yet. And somehow, I think a lot of times as scientists, we're afraid to say, I don't know, because we think it will breed lack of confidence in what we do. But I think it actually flips the other way, that it breeds confidence when you are able to say what we don't know and what we do know. So the general point here is that clarity and honesty in how we talk about science really breeds confidence in the value of science. And we need people more than ever to be confident in the value of science. So as his talk made clear, convocation talk, the value of science, which has and will continue, the point of his talk was that science has just had an incredible impact on the health and well-being of human populations, especially in the last 100 and 200 years. And that's an important lesson for everybody in our community. So we're fortunate to have the clarity and vision and energy that he's brought to the School of Public Health. I think we'll find out and hear more in the coming, what he says and his colleagues say, that he's launched some really, really important educational and research initiatives at Brown, working to tackle some of the biggest challenges facing human health and health equity. Areas like pandemic response, disinformation, artificial intelligence, climate and health, and other things that many of you in this room are working on and interested in learning about. And he's promoted, and I think this is really important, an environment of innovation with leadership from faculty and students and staff and alumni. And he recognizes that solving the pressing problems of public health require interdisciplinary cooperation, teamwork, people from different areas coming together, and I think he really recognizes the need for representation from diverse perspectives and lived experiences if we're really going to make a dent in addressing some of the challenges we face. So I will just conclude by saying that my perception is that the school is growing and flourishing under his leadership, in large part because of the work of everybody in this room. And the undergraduate, master's, and doctoral programs are doing really well, and we're producing graduates who are going to go on and make a difference in the world. So thanks to all of you for everything you're doing. Thanks to Ashish Jha. Please join me in welcoming him today.
Thank you, President Paxson, not just for those excessively kind remarks, but really for your support, for your engagement, and for your belief that we can build a truly transformative school. So 3 years ago is when we started this tradition of doing an annual, and last year we had the 10th anniversary celebration, so that was our State of the School. If you go back to 3 years ago, we were still in pretty much the heart of the pandemic. We were a year out from the murder of George Floyd. We had one of the worst years in terms of the opioid epidemic. I think the health effects of climate change, which many of us have been worried about for years, was starting to be felt. And for the small number of you who were there 3 years ago, I know a few of you were, we talked about a public health moment, that this was a public health moment, and how we needed to turn it into a public health movement, that we needed to take the moment, not squander it, but to turn it into action that was going to make a difference. And so as we begin our 11th year, and thinking about the state of the school, I would say a few things. First, the state of the school is incredibly strong and growing stronger every day. Second, I really believe, and as you will hear over the next 45 minutes, not just from me, but from a whole series of your colleagues, my colleagues, I believe we have begun in a very substantial way to turn the public health moment we found ourselves in 4 years ago into a movement that is having real impact. So we should talk more about that. It's having impact, as Chris said, we are having impact certainly in our hometown, in our home state, Rhode Island. We care deeply about that. We are having national impact, and again, you'll hear from other folks who will lay this out for you, and we are having global impact. Now, the question is, how have we done this? The formula, I think, for academic success, for academic impact, in my view, is pretty straightforward. You get extraordinarily talented, creative people, students, faculty, and staff. You give them the tools that they need. And then if you're an academic leader, you get out of the way. You let them do their magic. That is certainly what I have learned when I have looked at great academic leaders like President Paxson, and that has been the formula that we have tried to implement. So, as I said, we are at a place where this school feels very different now than it did just 3 years ago, 4 years ago, when we started. And you are going to hear about what the school is doing from 6 different colleagues over the next 45 minutes. And these are people who are leading in their areas, students, faculty, staff, who will talk about the impact the school is having. And you know, the school, before I got here, was leading in so many areas. We were doing, I think, the most cutting-edge work, thinking about how you care for an aging population, how we think about substance use disorders like alcohol and tobacco, and how taking a harm reduction approach can really have a very meaningful public health impact. We were doing extraordinary work thinking about global issues like tuberculosis and HIV, and how we bring behavioral sciences to managing those diseases. We've obviously expanded on a lot of that work. And I want to get specifically into some of the specific areas where we've expanded and some of the places where I think we're having very substantial impact. And you know, anytime you put together a talk like this, the hardest part is that you can only talk about just a fraction of the work that is happening at the school. If I try to do a survey and talk about everything great that I think is happening at the school, we would be here till 9 p.m. and I'd probably not do any of it justice. So this is really just a sample of what I think are some of the most important initiatives, but there are a lot of really other important things that we're not going to be able to cover today. But I want to start this conversation by talking about climate change. So a fundamental insight of public health is that our health is shaped by the environment around us. If you don't, that is what we in public health believe. It is shaped by our families, by our communities, by the cities we live in, by the country we live in, by the policies that surround us, and certainly the environment that surrounds us. And that is what makes climate change such a strong and important example for us to think about. It is in some ways, and people have described it, it is the ultimate threat multiplier. The climate change itself is not a direct threat to human health, but it takes all of these other threats to human health and makes them worse. And you know what those are. Major storms and flooding and droughts and displacement of individuals, pollution, wildfires, and of course heat waves. It's interesting to me to realize July 21st of this year was the hottest day ever recorded on this planet. And July 22nd, the day after, eclipsed that record. And there's no reason to believe that July 22nd, 2024 will maintain that record for any extended period of time. If you look at the records of the last few years, my expectation is next year or the year after, these records will be broken. So we are entering a very complicated moment. And there is so much innovative and important work happening across the school. And before I ask one of my colleagues, one of our newest colleagues, to come up and talk about his work and how he's thought about it, I want to just give you a flavor for the breadth of work that is happening across the school. So we know that the healthcare system, which we all care deeply about, probably represents 9-10% of all greenhouse gases in the country. And really important work by Emily Hoff and Ariel Cohen last year focused on the carbon problem of the healthcare system, both its contributions and what the healthcare system can do to reduce its carbon footprint. Those of you who know Stephanie Friedoff in the Information Futures Lab know the work she has done on the Listening Project, which went out into communities in Rhode Island and asked people, not experts, not officials, but everyday people, everyday Rhode Islanders, about how they thought about it, how they experienced climate change. And it was extraordinary because it led to a set of insights that I would have never had about what was happening with climate change and how people were experiencing it. And then you have people like Erica Walker, whose work on wood pellets or on noise pollution and how they interact with heat is really reshaping the way we think about environmental impacts. So I want to use this moment to invite our first colleague up, Corey Ziegler. Corey has been a member of our community for a month and a half now. We stole him from the University of Texas at Austin. He does extraordinary work, which I am not going to get into because I'm going to ask Corey to talk a little bit about his work. And as you come up, I will say, as Corey had signed on the dotted line and was coming at this year's COP, it was really fun to listen to John Kerry praise Corey's work as really revolutionary in helping us think about different forms of air pollution or carbon pollution and the differential impact it has on health. But let me stop talking and turn it over to Corey Ziegler.
All right. Thank you, Dean Shaw. I'm really pleased to be here, and I'm thrilled to have so recently joined the Department of Biostatistics here at the school. And I want to relay a personal story that reminds me of why I feel so privileged to be doing climate and environmental research from the position of a school of public health. And in particular, a school of public health like this one, that's coming of age at a time when climate change is really at the forefront as a public health crisis. Climate change research is everywhere on a campus like this, as well it should be. But this story reminds me of how our shared mission of public health impact can really propel certain types of interdisciplinary work that are hard to achieve in other contexts. So the story is this. Years ago, as an assistant professor in a school of public health, I had some ideas on how to evaluate the health impacts of various air pollution and climate change regulations. And I was pretty immediately struck by the interdisciplinary demands of doing this type of work. One thing we needed was some sort of engineering model for how air pollution moves, say, from the smokestack of a coal power plant into somebody's lungs who might live hundreds of kilometers away. Engineers have tools kind of like this, but nothing that was really designed for the needs of, say, an epidemiologist. But I had some ideas, and pretty early on in this process, I had the chance to essentially pitch those ideas to some atmospheric science professors. These were not people in the School of Public Health. They were appointed across engineering departments in another school. I started to explain to them my ideas, and they sat across the table from me, and they sort of shook their heads, and they're like, no. This is not what you want to do. This is too simplistic. This will never work. This is just not how we do things. And so as an assistant professor receiving this type of feedback, I might have just dropped it right there. These were smart people. They knew what they were talking about. But I didn't drop it. And a few years later, with the right set of collaborators, the work started to get some traction. And epidemiologists, EPA scientists, they started to contact us about using the tools we were developing, and the impact started to come. We provided some new evidence for how closing a few coal power plants was impacting asthma in downwind communities. We showed how some renewable energy policies were offsetting fossil fuel generation and how that distributed health benefits across the country. We were able to identify which power plants in the US were killing the most people, and we were helping EPA regulators navigate an evolving political and scientific landscape around causal inference. And so academia can be frustratingly siloed at times. Those engineering professors, they were primed to evaluate an idea based on its potential to impact engineering. Statistics colleagues I would explain to them my ideas, and they'd be primed to evaluate those ideas based on their potential to impact statistics. But the silos of academia are just not as distinct in a school of public health like this, where our shared mission of public health impact can really prime us to think above and beyond any individual discipline when the problem demands it. And so while we advance our respective disciplines with research and education, I always remind myself that we in a school of public health have the privilege, have the luxury to think bigger when the problem demands it, which is exactly what we're going to need to do to address the public health challenges of climate change. Thanks.
Thank you, Corey. So thank you, Corey, and really multidisciplinary at the heart of this work. I think one of the lessons that I have learned over the years is if we're going to try to solve the big problems facing human health, that we have to work at the interfaces. And Corey is just one example of a researcher doing that. In the climate space, Alan Just, Rachel Baker, we just have extraordinary people who are thinking about how do you cross those intellectual boundaries. So as we think about climate change, and I mentioned some of the effects that it's going to have on health. One of them that I didn't mention, a bit on purpose, because I wanted to use it to talk about the next topic, is the way climate change is affecting infectious disease spread. A lot of us talk about, and have been talking for a decade now, about how we're entering an age of pandemics. Sounds scary, but I think it is a situation where if we do things well, we can manage our way through it. And why do we say we're entering an age of pandemics? Because climate change is affecting disease vectors and where they are. Deforestation means more human-animal interactions. Globalization means outbreaks in a local place becomes global immediately. And then last but certainly not least, over the last decade, something else has happened, which is we have figured out how to engineer biology. And every time we have figured out how to engineer a scientific field, you see the rise of weapons in those areas, whether it was chemical engineering leading to chemical weapons, engineering physics leading to nuclear weapons. And so we are entering an era where both man-made and natural global threats, biological threats, are going to become more and more the norm. We can either hide under the bed and say, this is terrible, I don't want to live in that world, or we can get going on preparing for it and managing it in a way that doesn't disrupt our lives, that doesn't kill people, that really lets us get through this time period that we are entering. And one of the things that I have been very excited about is the work that has been going on in the Pandemic Center. It really focuses both on natural threats and man-made threats, person-made, human-made threats, led very ably by Jennifer Nuzzo, who's been doing extraordinary work. And there's a lot of different things that are happening in the Pandemic Center. I'm not going to list all of them. But one of the things I really love about the work of the Pandemic Center is how incredibly bipartisan it has been. Just a couple of months ago, I was in Washington for an event for the Pandemic Center where we brought together political leaders, governors, mayors, health officials from across the political spectrum, Republicans and Democrats. Because we know, first of all, these threats don't really differentiate between liberals and conservatives, Democrats and Republicans. Second, in order for these threats to be managed effectively, you need political leaders across the political spectrum who are going to follow the scientific basis and evidence, who are going to put in smart policies. And the good news is they exist across the political spectrum. And to highlight that has been a really important thing. And the last but not least, and I'm going to ask my colleague Wilmot James to come up and talk a little bit about this, is while we think of this as, okay, so we had COVID and we talk about COVID in the US, of course, pandemics by definition are global. They are global threats. And if we're going to be effective in surveillance, if we're going to be effective in response, we have to do this with a much more of a global eye. And therefore, when Jennifer Nuzzo first approached me not that long ago, a year and a half ago, with the idea that we could get Professor Wilmot James to join us at Brown, my first response was, get out of here. I'm never getting Wilmot. Well, I am thrilled to say that while I have a lot of colleagues here that I admire and respect, there are very few who really make me feel humbled every day. Wilmot is certainly one of them. And without getting more into his topic, I do want him to talk a little bit about the work you're doing, but particularly the game changers, which I think has been so extraordinary. But Professor James.
So I'm very grateful to have the opportunity to speak with you today about the fact that the global health security community has focused on three very important tasks that we need to tackle as we leave COVID-19. The first is to train the next generation of health security experts and to network them globally. The second is to strengthen surveillance systems, including for climate-sensitive diseases, and to build out what's known as event-based surveillance across the globe. And the third task is to decentralize vaccine manufacturing. And we have to do this under circumstances where we have to keep frontline health workers safe, and we have to keep communities safe. And the second aspect is to keep dangerous pathogens and toxins out of the hands of people who want to cause harm. And that is not easy because of the changing face of biology and the ability today where you can see machine learning and artificial intelligence power a whole range of things that are good, including diagnostics and surveillance, but also creates massive risks. And what we need to do, which is a challenge, is build new biosecurity tools to deal with those threats. And those tools have to be cybersecurity sensitive and a range of other things. But that's the hymn sheet of what it is we need to do. So at the School of Public Health, at Brown, and at the Pandemic Center, this is our contribution to dealing with those challenges. The first is that I teach with somebody called Beth Cameron a course this afternoon at 5 o'clock called Biosecurity Game Changers. I am by background both an academic and a former legislator, and so this is a policy course about what it is you need to do when you have not perfect information under circumstances of duress during a pandemic. This is a policy course that is also an implementation course. This is not something universities normally do. Universities have three purposes: research, teaching, and convening. This is about implementation in the real world. So we then teach this course at Brown, but we last week launched in Addis Ababa with the Africa Center for Disease Control a global fellowships program for young, talented individuals, both in the US and in Africa, who are already in employment, get an additional stipend and be placed at global entities like Gavi, CEPI, the World Health Emergency Operations, also fellows at Brown. So we've selected for the first round 10 fellows who are already in employment to spend time with global entities in health. If we do this intake, 10 fellows a year over the next 5 years, we'll have 50. So that's our first contribution, is to train the next generation. The second project, just two elements, is to introduce much faster and smarter early detection and early warning systems as part of normal surveillance. And we've got two projects to deal with it. The first is one called AWARE, which is funded by the Gates Ventures, Gates Foundation, and Wellcome Trust, is to harvest best practice when it comes to early warning and early surveillance, both of pathogens and of disease patterns, including climate-sensitive ones, beyond the obvious ones about how intensified rainfall will change vector-borne diseases. So that's one project that's linked to that. The second one is with the WHO Hub in Berlin, the Global Partnership, the Robert Koch Institute, and the Africa Center for Disease Control is to bolster surveillance systems in 8 African countries, including Tunisia, Morocco, Mali, Gambia, South Africa, Namibia, and 2 others. Part of that story has to do with being able to develop, which is why the Robert Koch Institute is involved, being able to develop tools to deal with how you develop new biosecurity tools to deal with the fact that, for example, you pick up with wastewater surveillance a genetic sequence that you need to recognize and attribute, and how do you do that? The third project is that we've started an initiative to train a new generation of regulators for clinical trials and for medical countermeasure approvals, including vaccines, on the African continent. That's a project we're doing together with the University of the Witwatersrand in Johannesburg. Let me say that's our contribution as Brown University to what are global issues to do with surveillance, to do with training, and to do with decentralized vaccine manufacturing. But we do it in a setting where within the School of Public Health, there's an architecture of collaboration and partnership. Outside of the School of Public Health, we work together with the School of Professional Studies. We do it with the Watson Institute. We're building relationships with engineering across the campus in order to serve that mission. We cannot do this alone. And then we build it together with global partners, WHO, Africa Center for Disease Control. Just to return to Ashisha's point, the risk landscape has changed with synthetic biology and machine learning and artificial intelligence applications. And we know what the benefits are, we think. We begin to show we actually don't know what the risks are. We don't know how to deal with it. So we have to build out a program to deal with it. So in short, let me just say that it's wonderful to be at Brown because of the collaborative spirit and incentive architecture this institution has built over time. Many thanks.
Thank you very much. It's hard to overstate the impact of the work that is happening at the Pandemic Center. And he mentioned Beth Cameron. Beth was the former senior director for biosecurity in the National Security Council inside the White House. and continues to just be a really important force for our students and our faculty who are interested in these issues. And the last point I will make, as I was listening to Wilmot, and by the way, none of these speakers shared with me what they were going to say, so I'm kind of reacting as I listen to them. That, you know, during the pandemic, I had a conversation at one point with John Nkengasong, who was the head of the founding director of the Africa CDC. And he made a point, and it was a painful point, and I think I could sort of feel the pain in his voice when he said it. We were talking about vaccines and how hard it was to get vaccines to the African continent. And he said, you know, Ashish, this is the last pandemic where Africa will leave its destiny to others. We will solve our own problems in the future. And what the Pandemic Center is doing under Wilmot's leadership is looking at that list of things that need solving. And instead of being daunted by it, instead of being paralyzed by it, saying, let's get going. And they are really doing extraordinary work to make that vision that the African continent should not be reliant on anyone else in future pandemics, in future crises, actually come to fruition. So Wilmot, thank you for your leadership. You know, we often say in public health, and a lot of public health people often talk about how the healthcare system is, you know, only influences a small part of health outcomes. And that's somewhat right, but it's also not quite right. And let me explain. So, of course, we all understand the broad set of social factors that determine health outcomes, right? From housing and food access, to employment, to the environment. Those, of course, matter enormously. But turns out that a really effective health system, healthcare delivery system, can mitigate against a lot of those harms, can improve people's health by allowing us to use the incredible gains we've had in medicine. And so thinking about high-performing health systems very much belongs in a public health school. And the policies that shape that certainly belong in a public health school. And in the last 4 years, the school has made pretty substantial investments in building out our policy shops. 2 big new centers, Chess and Caper. The first one really focuses on the fact, it's led by Irene Papanikolaou, who we recruited from the London School of Economics. And Irene and colleagues, basically their work focuses on the notion that the challenges facing health systems are not uniquely American. Even though sometimes we think, well, ours is the worst system of all, it turns out pretty much every single country, when you talk to policy leaders in every country, from the UK to Switzerland to Japan, they all point out that they have problems with access, quality, and costs. So no one has figured this out completely. Now, we do certain things particularly badly, don't get me wrong, but these are challenges that are universal, and the fundamental belief behind that center is that we all have a lot to learn from each other. The second center, and I'm going to ask my colleague Yashashwini Singh to come up and talk a little bit about some of her work and the work happening under Caper, is led very ably by Andy Ryan, focused on much more domestic health policy issues, with the idea that we have a long history of making health policy in the United States that's not particularly evidence-based. And if we can change that, we can get to much better policies. Better policies lead to better systems lead to better health and health outcomes. At least that's the hypothesis, and it's certainly one I believe. And this center, I would argue, has very quickly become the place that does the best work on Medicare Advantage, on private equity, and a whole host of other issues. So another new colleague, not quite as new as Corey, but has been with us only for a short period of time, Professor Yashashwini Singh. Thank you for joining us and saying a few things.
Good afternoon, everybody, and thank you very much, Dean Chia, for the opportunity to share my work with you all today. It's an honor and a privilege. There's been a long-standing tension between medicine as a profession and healthcare as a business. The key concern has always been that corporations' obligations to their investors or shareholders might not always align with physician obligations to their patients. My research unpacks this tension in the context of evolving trends in corporate consolidation in the American healthcare system. Now, as we know at the School of Public Health, I don't need to belabor this point to this audience, but the United States has a market-based healthcare system. So we really rely on competitive markets to work in terms of ensuring fair prices and a certain level of quality and outcomes, quality and access outcomes. The problem, though, is that in general, healthcare markets don't work very well, and in general, we don't have the type or the level of competition we need to ensure efficient outcomes. More recently, there has been a steady increase in private capital flowing into healthcare, most notably from private equity firms. Now, private equity, or PE firms, have been around for a long time, but healthcare has emerged as a lucrative target only recently. What is PE? PE firms, for the most part, invest in companies to generate short-term financial returns for their investors. In healthcare, PE firms have invested over $1 trillion in the last decade in every setting where care is delivered from cradle to grave. So think primary care, fertility, neonatal services, cardiology, oncology, even nursing homes and assisted living facilities. PE firms currently own more than 400 of the nation's 5,000 hospitals, and they employ over a third of the country's emergency room docs. While these numbers are striking, I must also note that they are likely to be underestimates because there are no systematic reporting or disclosure requirements for PE deals. So my research is based on unpacking these trends in corporate consolidation to understand what are the effects of growing corporatization, specifically private equity investments in healthcare. While every acquisition is different, there are a few takeaways that I'd like to share with you today. First, when PE firms buy a physician practice, healthcare costs go up. Doctors are made to see more patients, perform more tests, often with uncertain or outright harmful implications for the quality of care. In other areas, PE firms we've seen are known to strip real estate assets and cut critical but less profitable services from hospitals. The consequences for patients and the healthcare workers are still unfolding. Now, I want to emphasize that markets are not perfect. All markets fail, and all markets, particularly those for healthcare services, require oversight and external support to maintain competition and generate efficient outcomes. So given this, a question that I often ask myself, and I encourage students, colleagues, collaborators, and so on to spend time thinking about is, what is the role of public policy in ensuring that the incentives of private equity firms align with the incentives of doctors, patients, healthcare workers, taxpayers, on and on. Policymakers paying attention have opened up a unique window of opportunity for us to do something. In Congress, the Senate Budget Committee is investigating PE ownership of hospitals with bipartisan support, while the Senate Homeland Security Committee is probing PE in emergency departments. The Federal Trade Commission also just last year brought the first of its kind antitrust lawsuit against PE-backed physician practices. Together with my colleagues at the Center for Advancing Health Policy through Research, I have had the enormous privilege to engage with federal and state policymakers on not just the implications of my research, but also to provide policymakers with policy options to consider. This has led to briefings with the White House and the Federal Trade Commission to give policymakers the relevant data and the facts to make evidence-based policymaking. We are also continuing to work with congressional staff to provide feedback on legislative provisions to enhance ownership transparency, because you can't solve a problem you can't see, and strengthen oversight of healthcare mergers and acquisitions. I want to end by acknowledging the unique research environment at Brown and the School of Public Health in particular, which has been a key ingredient in my ability to conduct this research, but also use it to inform concrete steps to improve the American healthcare system. Thank you for the opportunity.
Great. Thank you. Thank you, Professor Singh. And I will say that, as Yashwini said, I mean, the extraordinary impact this group is having, meeting on a regular basis with congressional leaders, with the White House, with FTC, is exactly where we want to be at Brown. We want to do really world-class research, and we want to turn it into action. And the way you do that is by engaging directly with policymakers. Now, one area that really could use more and better policy making is another huge public health challenge, and that is the problem of opioid overdoses and substance use disorders. For the first time in many years last year, we saw a little dip in the number of Americans who died from opioid overdoses, but still close to 100,000, about 90,000 Americans died last year. That is an extraordinary toll, especially when you think about how many young people there were who died unnecessarily. And the School of Public Health is really leading the way, in my view, on policy and impact on this work. Certainly on trying to expand access to treatments, but also an innovation in how we do harm reduction. And so I'm going to ask my colleague Julia Noguchi, who is a research scientist in the People, Places, and Health Collective that has been at the forefront in Rhode Island, and Rhode Island has been in the forefront nationally in thinking about how do we do harm reduction, how do we reduce the number of people who are dying of overdoses. So Julia, thank you so much for being here.
Good afternoon, everyone, and thank you, Dr. Jha, for the warm welcome and for this opportunity to speak on behalf of the work of the People, Place, and Health Collective, which we call the PPHC. I'm also very new to this work. I have Corey beat by maybe several months, so I feel very privileged to speak about this work, which others in my lab are much more well qualified to do. So for those of you who are not familiar with the PPHC, we are a research and policy lab co-led by Dr. Brandon Marshall and Dr. Francesca Bodwin, both in the Epi department at the School of Public Health. At the PPHC, we work with other Brown faculty, students, and external collaborators, including state agencies, policymakers, and community-based partners, to produce and disseminate evidence-based, data-driven research on overdose prevention and harm reduction. One unique quality of the PPHC is that our work is primarily done locally, but it's increasingly having a national impact. For example, the PPHC is privileged to be leading the evaluation of the federally funded Overdose Prevention Center that will open this fall in Providence. The OPC will be operated by a local harm reduction agency called Project Weber Renew, which I'm sure many of you are familiar with. Opioid overdose has been named one of the most significant public health crises of our time. Fatal drug overdoses, which have largely been driven by fentanyl and xylazine locally in the unregulated drug supply, have been on the rise in Rhode Island since 2014. And just last year claimed over 400 lives. And this is just a personal anecdote. The day before yesterday, I called one of our community collaborators at Project Weber Renew just to talk about a trivial work matter, and he didn't answer the phone. He called me back later that evening to say that he didn't pick up when I called because he was in the middle of reversing an overdose. This was happening outside of his office window in the parking lot of Project Weber Renew. I tell this story not to illustrate how pervasive the problem is. Everybody in this room knows that. But it's an example of why harm reduction is so critical. Harm reduction has a broad definition, and it incorporates evidence-based practices like using clean needles and sterile water and keeping naloxone nearby in case of an overdose. But harm reduction is most importantly a philosophy, one that empowers people who use drugs with the choice to live self-directed lives. There's no doubt that data and research are critically important, but fundamentally, harm reduction is about non-judgment and centering individuals and communities. This type of research is challenging and imperfect, and as researchers, we don't always get it right. It requires patience, humility, and active listening. However, it's rewarding and incredibly exciting to witness incremental change at the local level. And if anybody is interested in learning more about overdose prevention centers, I do encourage you to check out the PPHC's website, opc.org, to learn more about how OPCs affect health outcomes. So thank you again for the opportunity, and best wishes to all in the coming year. Thank you.
Thank you. You know, it's interesting, as you talked about, that PPHC is very focused on Rhode Island and as a state, and that is unto itself very important. I always remind people most national policy on most important issues happen because a state takes a leadership role, does something well, and lots of other states say, ooh, that's an interesting way to do things, and it sets off a momentum. It is actually rare that you can do something in terms of an evaluation or a program at the national scale immediately. So while this is really important for Rhode Island, I think it is going to have very large impacts nationally. I want to very quickly talk about public health at this moment more broadly. You know, for many, many years, I had to try to explain to people what was public health. They're like, is this government-run health? I'm like, no, that's not what I mean by public. I mean the public, like people. And the good news of the last 5 years is you no longer have to explain what is public health. It's supposed to be a sideline conversation, it has become front and center. But the bad news is that it has also become ripe for bad information and the spread of bad information. And then you tie that in with all sorts of new technologies, smartphones, social media, and we have seen the proliferation of bad information and the impact it has on people's mental health and well-being. And while I'm not going to ask somebody to come up and speak about this, I do want to take a minute to talk about the extraordinary work being done at the school to understand and counter these effects. And I think about the social media and youth mental health project being done at the Hassenfeld Institute under Mike Silverstein's leadership. And I think about all of the work on misinformation and both understanding it and countering it that's happening at the Information Futures Lab under Stephanie Friedoff's leadership, and a lot more. I want to shift gears a little bit to talk about something else that has happened in the school over the last few years. And that is the extraordinary growth of our educational programs. Currently, in this academic year, we have about 550 graduate students at the Brown School of Public Health. It's made up of traditional master's students, traditional MPH students, online MPH students, accelerated MPH students. We have a Master's of Biostatistics, which is growing by leaps and bounds, and that's the traditional program. We're going to be launching an online Master's of Biostatistics. And then last but certainly not least, we have an extraordinarily competitive, very, very high quality PhD program that I think is training some of the best academic and non-academic experts. And this work has really happened under the leadership of Ron Aubert, who's our Senior Associate Dean for Education, Francesca Bowden, who's our Academic Dean, and in super close collaboration with Shankar Prasad, who is the Dean of the School of Professional Studies. As we have grown, the hardest part about growth, and this much growth in education, has been making sure we stay true to our core values, and that is that every student, every new student, every old student, every program needs to continue to get that Brown experience. The unique way in which Brown thinks about education has remained really central. And so I'd like to ask Will Goodell, who is a graduate of our PhD program, is the winner of this year's Dean's Excellence in Classroom Teaching Award, to talk about some of the work that's been happening in education in the classroom and beyond, and how we continue to both grow and make sure people benefit from our educational programs, but do it in a way that keeps to the Brown tradition. Will.
Thank you, Dean John. Good afternoon, everyone. It's really a joy to be here. I'm an assistant professor in the epidemiology department, and I spend most of my time in our classroom. And it's one of the
best parts of my life. As Dean John mentioned, I am the very happy product of a Brown education in public health, and I try to pay all the good that was given to me back in the classroom every single day. I'm fortunate enough to have been given the honor to teach students who range from those who I meet when I'm helping them choose the very first courses they take as undergraduates, all the way up to the students who I get to proudly recommend for the conferral of their doctoral degrees as the director of our PhD program. I occupy kind of a unique space in that every single one of my classes is for a different degree level. So I see undergrads in their first epidemiology classes. I see doctoral students before they say, I'm done taking classes now, let me fly. And so in thinking about what I wanted to say about the state of classroom teaching at the School of Public Health, I really thought about what I lectured on this week in my 2 classes, because that's what's taking up all the space in my brain, I think, my first full week back in the classroom after a couple months, where I've really started with the building blocks of epidemiology in both classes. So for my undergrads, who I taught this morning, we've started to talk about how whenever we want to understand a public health problem as epidemiologists, we need to know some basic things: how many people have the health condition we're interested in. And we know that that number alone isn't enough. It needs to be paired with an epidemiologist's favorite thing, a denominator, that puts it in context. It starts to give us answers to the who and what and how much of whatever issue we face so that we have a solid understanding of where we need to be when we address many of the pressing public health challenges that my colleagues have already started to discuss today. For my graduate students who I taught last night, we spent the week talking about how we can think about the role of place in public health, answering questions about where public health actions are most needed. And so when I think about why I feel so honored to be at the front of a classroom at the School of Public Health, I think about those same building blocks: who, what, where, and how much. At the School of Public Health, our students come to our classes ready to figure out who they want to be in the world, what impact they want to have, where they want their education to take them, and all perhaps without realizing how much they inspire all of us as faculty and as staff to grow and improve. You know, one of the beautiful things about being a teaching scholar at the School of Public Health is that my classroom teaching informs my research and back again. And I find that as I have to revisit these building blocks in epidemiology regularly every single year, I get the chance to reconsider how much more clearly can I communicate a concept? How much more simply can I make it so that everybody understands that they have a role in furthering the health of all of our communities? As a School of Public Health, I always say that we need to appropriately invest in what happens in our classrooms so that our students go out into the world with the knowledge, skills, courage, and determination to make change happen where it is most urgently needed. It really is a true privilege to play one small part in training the next generation of leaders in public health. And over the next academic year, I hope that we continue to work together to excel in our teaching. So I thank everybody who makes it all happen. The faculty get to stand up at the front of the room and get all the credit, but there are a lot of staff who make it all possible so that we have everything that we need to deliver our courses effectively. So I thank you all, because there are many of you in the audience, and I thank you for giving me the moment to speak.
Thank you, Will. Will brings up a point that cannot be emphasized enough, which is we often talk about the students and the faculty, and they are, of course, very important, but it all happens because of the incredible staff that we have at our school and the way they work and really the thankless hours that they put into making everything work. So that, I think, is very important. There's been a lot of growth at the school. You all know that we have been growing at 121, adding more floors, not actually physically adding more floors, so that would be lovely. We have a building next door, 155, that we are working on being able to move more of our faculty, students, and staff into. And then we have space in Washington, D.C. That we have opened up because we want to have impact on policy and all the organizations and all the activities that's going on in DC as well. And it's a reminder that physical space matters, where you are matters. And we're also reminded of that on a daily basis when we think about where we are as a school, not physically like 121 South Main, but Providence and Rhode Island. And if we're gonna have impact, and we always talk about we're a school that learns public health by doing public health, then it's going to require really deep engagement in our community. And this is an area where I would say we have doubled down very substantially. And it has been helped enormously by great leadership from Sarah Bouchard, who's our Director of Community Engagement, who I think has been doing extraordinary work in this area. We have a whole series of partnerships. I will not run through all of them. A few that I'm particularly proud of. The Rhode Island Life Index. It's something that Melissa Clark does a lot of the really important work in surveying and tracking the life and health and well-being of Rhode Islanders. And we put that out every year in close partnership with Blue Cross Blue Shield of Rhode Island. And our students are out in the community-based organizations doing what I think is really fundamentally important work, not just in contributing, but learning from these communities. And this morning, I spent a couple of hours with the leadership and at the annual conference of the Neighborhood Health Plan. For those of you who don't know Neighborhood Health Plan, I would say you should take a few minutes at some point and look them up and learn about them. They're the largest Medicaid provider or insurer in the state. They're one of the highest ranked Medicaid programs in the country. They really do extraordinary work, and they bring public health and medicine together in a way that I have not seen very many health plans be able to do. Now, as I said, there are a lot of great experience, a lot of great relationships, and I'm going to ask my colleague Petra Smith to come up, a great student in our master's program, to talk about one of those relationships that I'm particularly proud of. And it's our relationship with Clinic Esperanza, and I am not going to talk more about it because Petra will. Petra.
Thank you, Dean Jha, for the opportunity to speak and for expressing interest in my work. As mentioned, my name is Petra Smith, and I'm a second-year MPH student and a member of the Health Equity Scholar Program. I have to say that being asked to speak about my community engagement was definitely a bit of a reflective moment for me, because I really came into this program interested in getting involved in community-based work. Growing up in Rhode Island, I was always adamant that I wouldn't be one of those Rhode Islanders who hangs around forever. In fact, I actually went all the way to Canada for my undergrad. But as I started working for the Rhode Island Department of Health as a Spanish-speaking COVID-19 case investigator, everything began to change. I started to see firsthand the barriers to care that the Rhode Island Latino immigrant communities were facing, and I became very motivated to come back and work to improving access to culturally and linguistically competent care. And so I came back to Rhode Island and proved true the stereotype that Rhode Islanders never leave. Since I was interested in this community-facing work, in my first few weeks here, I went to the Office of Community Engagement, and with the help of Sarah Bouchard, I was connected with Clinic Esperanza. For those of you who don't know, Clinic Esperanza, or Hope Clinic, is a free clinic here in Providence, over in Olneyville, and it serves uninsured adult Rhode Islanders, the majority of whom are Spanish-speaking immigrants from Central and South America. I started there as a volunteer, and since it was such a great fit, I decided to do my MPH practicum with them. I took on the role of project manager for one of their community vaccine initiatives, and I spent the summer going around Rhode Island, organizing a number of different mobile clinics to provide free vaccines. We were at churches, block parties, at the Smith Hill Block Party. We were with the Nonviolence Institute. And even this morning, I was over at Sojourner House, a women's shelter, and we gave out, I think, around 16 different vaccines. My work at these community vaccine clinics has been a perfect complement to my MPH program. I'm applying the biostat skills to analyze the vaccination rates. I'm using health communication skills when I'm designing educational outreach materials in English and Spanish. And the leadership development training that I receive as a part of the Health Equity Scholar Program has been monumental, especially as I'm now managing a multidisciplinary and multilingual team of providers, administrators, community partners, and community health workers. Most importantly, though, I think that I'm learning the true meaning of what it is to work with communities. I learned the hard way that social media posts do not have nearly as big of an impact as going door to door down on Elmwood Ave and Broad Street and handing out flyers. And I've really learned the value of leading while also listening and learning from community members. In fact, I'd say some of the best ideas from this community vaccine clinic have come from Avelina, who's the Washington Park librarian, and Luz, a community health worker and beloved Zumba instructor over at Clinica Esperanza. As I now move into the second year of my MPH program and inevitably thesis work and classwork starts to pile up, I'm very glad to be grounded by this community-engaged work. Whether I am graciously giving a vaccine to an immigrant family or I'm engaged in a heated discussion about the hesitations of a self-proclaimed naturopath, something we see a lot of out there, I'm constantly reminded of, one, my motivation to study public health, and two, my motivation to come back to Rhode Island, a decision that I now know is the right one. Thank you.
All right. So just a few more remarks stand between me and reception. So let me wrap up here by saying this has been an extraordinary decade at the Brown School of Public Health. And it really builds on a long-standing tradition of public health activity, work at Brown University. While the school may be young, training in public health and activities in public health are not. At commencement, I talked about how the health commissioner of Providence during the 1918 flu pandemic was a Brown graduate who had studied some basic principles of public health when he had been a Brown undergrad. One of the extraordinary things about this university as a public health person is we have a robust undergraduate program. Last year we graduated 74 concentrators, but we literally have hundreds and hundreds and hundreds of undergraduates who take our courses, who are part of our community, and who really elevate public health in ways that I think are really important. And it was interesting in a conversation I was having with a faculty member who said, do you want more people to become concentrators? I said, sure, that'd be great. But I'm okay if the economist, the person who's an economics concentrator or a history concentrator or a computer science concentrator takes 1 or 2 classes in public health. Because it shapes the work they do in economics, it shapes the work they do in computer science. It helps them see the world just a little bit differently. The goal is not to turn everybody into a public health person, is to instill a little bit of that public health ethic into as broad a range of leaders as possible. And that's where Brown has been extraordinary as a place that really builds the next generation of leaders. Let me wrap up by saying, the last 4 years, been here for 4 years, left for a part of it, came back happily, have been extraordinary 4 years for public health. And I think it's been an extraordinary 4 years for this school, largely because of all of you. We really did take what I thought was an unusual, once-in-a-century, once-in-a-lifetime public health moment and have turned it into a movement, but what we really meant is we've turned it into great research, a substantially expanded and even higher quality educational experience, and real translation, and you heard that. From Corey's work to Wilmot's work, I'm not going to repeat everybody that came up here, but real world impact in a way that only Brown can do. And I think, no question about it, we have a lot more work to do. We need to get better prepared for other health crises that will follow. We need to do a better job of adapting and mitigating against the health effects of climate change. We need to build better health systems and better health policy. We need to build a better information ecosystem. That is all work ahead of us. But I feel more confident and more optimistic than ever that this is the school to do it. That we have the right mix of students and faculty, and yes, absolutely our staff, to ask the hard questions, to push boundaries, to think and act in multidisciplinary ways, to commit to learning, and commit to continuing to do better. And by the way, I will say the speed with which our school has made these changes is breathtaking. 4 years. That is an extraordinarily short period of time for an academic institution. And it has happened because all of you have been willing to be flexible and willing to push boundaries and know that we are going to get to a stronger and better place. So one more time, I want to say that the state of our school is strong and getting stronger every single day. And I don't think I've ever been more optimistic or hopeful about the future of this school and about the future of public health. So thank you all for being here today. Thank you again, President Paxson, for your leadership and support. And beverages and food in the back.